Good everyone. It's my honor to share my experience in the vascular preparation for the endovascular treatment of calcified femoral popliteal artery lesions. The next slide. As we know, with the emergence of image of the DCB, the treatment of the peripheral artery disease is improved quickly. So with the DCB, we can improve the patency of the femoral popliteal artery without only standing. For the DCB treatment, we can live lower standing, and we give us a lot of chance to do the secondary performance. So with the treatment of the DCB, the vessel preparation is very important to make the smaller, reduce the severe recoil and severe dissection, and improve the absorb of the drug. So let me introduce some strategies for the vessel preparation. The next slide. As we know, the calcification is a very challenging for the current EVT treatment, because the calcification is difficult to dilation. The early recoil is limited the balloon angioplasty outcome, so the standing is needed for some calcified lesion. However, the hard COF causes the strong resistance for the standing of the optimal radial diameter. So next, the calcification is hard to make the absorption of the PTX of the into the medial layer of the vessel. Next. So let me introduce some evidence from our Chinese observational study. So we have a study for the calcified femoral popliteal artery disease. We try to find the clinical outcome of the endovascular treatment of the femoral popliteal artery. So we started the observational study from the 2020 to 2026 for 2 years follow-up for the clinical outcome. The next slide. From 2 years follow-up, we find the severe calcification was the independent risk factor for the outcome of the endovascular treatment. The next slide. So now in China, what modalities can be used in the severe calcification lesion? One is biomimetic stent, such as superior stenting. The next is the atherectomy device, such as the Tuberhawk and Jetstream. The third is now we want to discuss about the intravascular lithotripsy, laser tripsy device. The next slide, please. So before the availability of the IVL in China, we have to treat such calcified calcified lesions with standing. Supera is designed for a good radio focus for such lesions. So for such lesions, we can pre-dilate with 1:1 diameter for such occlusive lesions. Then we put the suprastent. But even though we have optimized dilation, such as we use the 5 millimeter pre-dilation, then implant the 4.5 millimeter supra. It also finds that there is still some stenosis in the stem, so it's hard to pre-dilation to the optimized diameter. So this is a case even use such a supra to such occlusive lesion. You find when we implant the supra stent in such target lesions, the diameter of the stent is not good to the purposed target diameter. So it's easily to cause the early occlusion of the target lesion. The next slide. After implantation of the supra without optimized diameter, we have to dilate again and again. However, the result is not good. So the Vibond, the cover stent, was implanted in the supra, and a high pressure balloon can be used to recanalization for the purposed diameter. Next slide. For such hard lesions with a lot of procedures with the standing, you can find a good result. So it's hard to use the common POBA to gain the lumen for the 5 or more diameter. So we have to use another techniques to give more lumen. The next slide. The directional atherectomy is another choice for such calcified lesions. With the atherectomy, we can remove the plaques from the percutaneous approach. We have the directional atherectomy or other optimal or laser atherectomy device. The next slide is always used in the no landing zone, such as the common femoral artery or the popliteal artery, to avoid the standing in such lesions, because we don't want to put stent in the CFA or popliteal artery. For CFA, we always use this zone for the anastomosis for the femoral popliteal bypass. For the popliteal artery, we need to avoid standing in such region, such zone, to avoid stent fracture. The next slide. From definitive AR study, this study compares the directional atherectomy plus DCB with the single DCB compare the two group, we find the dot have a larger lumen gain with lower standing rate. Even because this is a pilot study, we cannot find the superior outcome of the dot group compared with the DCB group. The next slide. From our study, we respectively observed the outcome of the dot of the 3 hospitals. We find the CTU length of the CTU is over than 10 centimeter is independent risk factors for the stenosis. However, we find in the dot group, the standing rate is only 4.1%. It's very lower than the POBA plus DCB group. The next slide. From the next study, the reality study, they observed the dot in the long calcified lesions. As we know, the dot definite AR is included only the short lesions. So how about the outcome of the DA in the long lesions? So this reality study includes the long lesions include such as over than 10 centimeters to 25 centimeters. And 39% of the lesions is CTU lesions. So next slide. From the reality, the 12 months results, the primary pendency of the 12 months is 76.57%. The standing rate is 8.8%. The next slide. So because this reality study is a single arm study, so we try to compare the long lesions with the single DCB with dot techniques. So we start this definite ALL study. We will include the CTU over than 5 centimeters, lower than the 15 centimeters, lesion length over than 15 centimeters. The next slide. So we started from the 2022 and we have included 31 patients. From the early reocclusion, we find some interesting outcome. We will show some 2 cases of the early reocclusion. They are also they are same in the dot group. The first one is a female, 49 years old. She had a right lower limb claudication. He experienced diameter and hypertension. ABI in the right limb is 0.66. From the angiogram, from pre-interventional angiogram, we find he has a CTU lesion over than 5 centimeters. Firstly, we try to recanalize this lesion in an integrated approach. However, the guideline is into the subintimal lumen. It's hard to find the true lumen in the distal vessel. So we try to reapproach puncture in the popliteal artery. After successful puncture into the popliteal artery, we use the CT01 to recanalize the lesion in a true lumen. After the wine into the proximal to lumen, we drop the wine outside and pre-dilation in with 2.5 millimeter unknown. Then we use the atherectomy with the tube hook. The next slide. After the atherectomy, we use the 5 millimeter DCB post dilation. The next slide. After the dilation with the DCB, only type B and type A dissection into the target lesion, so we don't put stent in such lesions and finish the procedure. The next slide. However, in the follow-up, this patient suffered with recurrent claudication, and after the CT-gram, we find the reocclusion in the right femoral popliteal artery, and compared with the pre-interventional CT-gram, we find the plaque is similar without any low removing result. So we can find any benefits of the atherectomy for such severe calcification lesions. The next slide. Next case is a male with right limb claudication. He also has a history of hypertension, diabetes. The ABI in right limb is 0.6. From the CT-gram, we find calcification in the right femoral popliteal artery and with over than 5 centimeter occlusion. The next slide. In the previous interventional angiogram, we also find the similar occlusion lesion length. So firstly, we try to recanalize the lesion in antegrade approach. The next slide. It's also it's very hard to recanalize in an antegrade approach. So the distal popliteal artery puncture is used to recanalize in the retrograde approach. After recanalized, we use the 3 millimeter pre-dilation with a proba. Then we use the atherectomy. Next slide. Similar approach have been used with in this patient pre-dilation and atherectomy, then use the DCB dilation. After DCB, we can find the pendant femoral popliteal artery without severe dissection. So we finish this procedure. And the next slide. Similar, after 3 months follow-up, the patient suffered with the recurrent claudication. From the CT-gram, we also find the reocclusion in the target lesion and similar burden of the calcification in the target lesion without any difference in the medial layer with the calcification. The next slide. So from the true occlusion in such cases, what the factors is limited for that in such cases. First, is long calcification CTUs. Next, circumferential calcification, and with the middle line calcification is limited for the good result of the atherectomy. The next slide. So we should use another technique such as intravascular laser trypsy to give our a larger lumen gain, lumen. The mechanical of the IVL is due to the serious image energy to transfer from the balloon to the calcified plaques. So it's benefit for the good vessel lumen gain, and without increase the injury of the layer of the vessel. And so after the microfracture in the calcified vessel is benefit for the drug delivery into the target lesion. The next slide. Yeah. Actually, from the previous study, we can find the optimal outcome of the IVL in the severe target lesions from the femoral popliteal artery to the infrapopliteal vessels. The next slide. Besides the interventional study, there are also a lot of observational study to evaluate the outcome of the LVA, even with the LVA complex combined with such atherectomy to treat such calcified lesions. The next slide. So for the second cases, we failed in the atherectomy. We use the IVL for the second cases. So let me show this the treatment of these cases. 这个是一个动态的，可以点击一下。
好的。
第一个，先点击第一个。So from the previous angiogram, we find the occlusion of the target lesions. Next slide. 那第二张也可以。Because this is early reocclusion for the patient, we concerned the thrombosis in the target lesion. So firstly, we use the thromboectomy procedure, such. The next slide. With the Rotrax. Firstly, from the angiogram in the occlusive femoral artery, popliteal artery, we find the thrombosis. So we use the Rotrax to remove the fresh thrombosis. After this procedure, we use IVL. The next slide. to treat the calcified lesions. Then we use the DCB. Compared with the previous procedure, we can find larger lumen after the IVL. So in the follow-up, till now is 6 months, there is still no restenosis from the ultrasound follow-up. So let me show another new strategy for the calcified lesions with LVL, DCB, and for the residual dissection, we use a bare-out spotting stent. This comes from a new standing study. So this is a male with 71 years old. He suffered with left limb claudication. The history of this patient has a stroke, diabetes, hypertension. The left limb ABI is 0.61. Similar, we recanalize the patient with the Dow approach. After draw out the guide wine from the retrograde approach, we use IVL to treat the lesion. Then we use 5 similar diameter for the DCB treatment. After the DCB treatment, we can see there are some type C, type D dissection. However, because the lumen gain is optimal and we believe the recoil is solved by the IVL, so we use the spot staining techniques. The next slide. The spot stain is 6 millimeter with 2 centimeters length. The series of spot stain we implanted into the dissection. The design of the spot stain is short standing without larger COF. So it's only to such a patch, such as a patch to the dissection without larger COF, and the risk of the stent refracture is very low. So after the spot stent, we recanalize the lesion with a good image. The next slide. So for such a new novel interventional LVL techniques, we now conduct a series of prospective observational study to draw the data and find the outcome of the clinical outcome of the IVL. So we conduct 2 prospective studies. So 10 hospitals have been attend such a multiple center prospective study. 2 studies have been conducted to draw the outcome of the LVL. One is a SHIELD study. The next STRIKE study, we try to evaluate the outcome of the IVL for such severe calcified lesions. The next slide. In a conclusion, heavy calcification is still a challenge for EVT in PAD patients. DA helps enlarge lumen by removing plaques, but is limited to calcified and subinternormal lesions. LVL achieve lumen gain via a series of sonic pressures that propagate through surrounding tissues and blood to the target calcified lesions, minimizing direct injury to the vessel. IVL works regardless of lesion length or subintermal approach and reduce rupture risk with lower pressure designs. Thank you very much.